So you all are students of second year. Okay. What have you learned so far in community medicine? Few words. Levels of prevention have you read? Primary prevention, secondary prevention, tertiary prevention. Natural history of disease, have you heard of this term? Natural history of disease. Suna hai? Huh? Can anyone tell me little bit natural history of disease? Suppose any infection. Can you tell me little bit about what happens? How does the infection begin? First of all, a pathogen will have to come and lodge in the body, isn't it? Once a pathogen lodges into the body, what will happen? What will happen? Infection will happen. So, infection is lodgment of a pathogen and its establishment into the human body, right. So, once it lodges and establishes itself, what will happen next? Disease directly? No, there are some steps which will have to happen before disease objectively happens. What will happen? There will be some pathological changes at the level, at the cellular level, isn't it? So, the pathogen will start to multiply, will start to create some changes at the level of the cells and tissues. So, there will be some pathological changes that will start to happen, but the infectious agent will have to multiply to a certain degree and will require pathological changes to a certain extent to be able to create or manifest clinical signs and symptoms, isn't it? Once clinical signs and symptoms become apparent, then we will realize that okay, disease has established onset, isn't it? We are then able to diagnose it as disease, and then the disease will run its course of progression, which will either lead in cure or death or disability, isn't it? So, this is the natural history of any infectious disease. Like this, there are non-infectious diseases also. Can you give me some examples of non-infectious diseases? Huh? Cancers. Good. Cancers are non-infectious diseases. Some cancers are infectious diseases also, but many cancers are non-infectious diseases. Anything else? Diabetes, hypertension, these are non-infectious diseases, right. So, what we are going to discuss today is screening for disease, okay, and we will try to understand what is screening, why we need to do screening. Okay, I will just introduce myself. I am Dr. Akash. I have joined here as assistant professor in the Department of Community Medicine, okay. Before this, I did my MBBS from Inapparent Medical College. I did my MD in Community Medicine from All India Institute of Hygiene and Public Health. Then I was working as senior resident initially in KPC Medical College, Kolkata, and then in All India Institute of Medical Sciences, Deoghar. And then I have joined here as assistant professor, okay. I have joined here as of middle of March. So, it is new days for me also. So, we are going to discuss screening for disease. So, while we discuss this, what we are going to do is that, what are we going to do? So, we are going to define, we are going to understand what screening is, why we do it, right. Now, before we understand screening, we must understand the concept of iceberg phenomenon of disease. Have you heard of this term? Iceberg phenomenon of disease? No. Okay. So, we will explain that. Next, we will enumerate what are the uses and the different types of screening, okay. Why screening is done and what types of screening are done. Then we will try to understand, okay, just because we can do screening, should we do screening, or are there certain criteria that must be fulfilled for us to do screening, right. And finally, we will look at what are the common screening tests that we routinely do in our healthcare system in India and abroad. And lastly, we will see what are the problems that can happen when we try and interpret the results of screening, okay. So, when I say the term screening, what comes to your mind? Huh? Anything. See, there is no right, it is good to be wrong. That means this class is required, and if you are right, then it is fantastic. So, what do you mean by screening? When I say screening for a disease, what comes to your mind? searching for signs and symptoms of a particular disease among. Okay, so I am thinking of a particular disease in mind and I am looking for the signs and symptoms of that particular disease. In whom? In a patient. Okay, so that is what we need to refine. Will we look only at the patient? When we look only for a specific disease, or will we look for objective signs and symptoms of disease or not? Okay, that is what we will discuss throughout the course of this. Now, why will you do this? Suppose you are looking for specific signs and symptoms of a particular disease in a patient. Why will you do it? To? Before cure, first to establish, to diagnose. Do we do screening to diagnose a disease? Okay, so these are the questions that we will try to understand. So we have raised some questions. What is screening? Who is the population on whom we will do screening? Right? And what is the purpose of screening? Screening screening करके होगा क्या? क्यों कर रहे? Diagnose करने के लिए कर रहे हैं क्या? क्यों कर रहे? है ना? So we'll try to understand these questions only. Okay. So let me go into the first slide. Just look at this diagram. What you can see is an iceberg, isn't it? You can see an iceberg. And what can you see in that iceberg? You can see that. Just describe what you can see, anyone. You describe what you can see. So there is an iceberg, there is a water level, there is a part of the iceberg which is above the iceberg, and there is a part of the iceberg which is below the water, isn't it? Now, which is larger? The part below is larger. As we know that when an iceberg floats, 11 out of 12 parts of it, 11/12 of it remains submerged and only 1/12 remains above, isn't it? So from here comes the idea of iceberg phenomenon of disease. So what is this? This says that for most diseases, what happens is the disease has a particular burden in the community. Now there is such a huge population. Not everyone is coming to the doctors. Not everyone is having the time and opportunity to come to the doctors. Not everyone is having the mode of transport to be able to come to the doctors. Not everyone feels the same sickness with equal amount of severity or intensity to come to the doctor at the same point, isn't it? As a result of this, we as the healthcare system or as hospitals or as doctors are not able to identify the entire burden of a particular disease in the community. So what we are able to see represents only a small part, a small proportion, and the large proportion of the disease remains hidden. That is what we think, and by that we present this analogy with the iceberg. What we say? We say that the floating part of the iceberg represents the diagnosed and the clinical cases. People who come, who seek care, who come to the hospitals, come to the doctors and get diagnosed and treated, right? And the submerged portion of the iceberg, it represents the asymptomatic cases, the latent cases, the pre-symptomatic cases, okay, and such ones, right? So the tip of the iceberg, it represents what the physician sees, isn't it? That is the clinical cases, the symptomatic patients. So whoever is a patient, whoever I am able to label as a patient has come to me, isn't it? So those I have been able to find out. For them we do diagnostic tests. To establish disease in patients, we do diagnostic tests. But other than that, there is a burden of the disease in the community. Like, see, few of you have come to this class. I can ask a question to you and I can assess how much you know about screening, right? From that I will think that, okay, out of these many, 4 do not know screening properly. So I am able to diagnose the deficiency of knowledge regarding screening among you. But there is a huge population of your batch whom I am not able to reach through this lecture, isn't it? Now among them, how many are aware about screening or how many are not aware about screening? How many are aware that they need to know screening or are aware that they will have some consequences of not knowing this? All of that knowledge is not there with me. That represents the submerged portion of the iceberg. So, what it represents? It represents the latent cases, the inapparent cases, the pre-symptomatic cases and the undiagnosed cases. Now, each word is separate. What is a latent case? So, suppose an infection happens. Immediately when the infection happens, after that pathogenesis begins, but the person does not show signs and symptoms. So, suppose an infection happens at this point. Suppose at this point an infection has happened at T1, right? Now, somewhere after T1 over here, this person starts to show symptoms at T3, right? Now, usually for most infectious diseases, what happens is people become infectious much before they start showing signs and symptoms. We saw that with COVID. People were not apparently sick with COVID but were spreading COVID, isn't it? So, there is a space somewhere here at T2 where people start spreading the disease. That is, they become infectious. Right. So, I get a pathogen multiplies, I start spreading that pathogen to others, and sometime later I develop signs and symptoms. So, this period between me contracting the infection and becoming infectious is known as the latent period. Okay? Me becoming infected and me becoming infectious is the latent period. Okay, and me becoming this is the pre-symptomatic period. Okay, this is the pre-symptomatic or asymptomatic period where I am infectious. So, I am spreading the disease, but I am not showing signs and symptoms. So, I am very, very dangerous at this point. I will give the disease to others, but I am not showing signs and symptoms, so people cannot be aware or protected against me, right. So, the first part is latent, which is still better. They have been infected but not yet infectious. The second part is they are infectious and they are spreading but they are not yet symptomatic. So, that is asymptomatic or pre-symptomatic, right. And then there are inapparent cases. What are inapparent? These are the subclinical cases. Some people have got the infection, spreading it, but never really develop the characteristic signs and symptoms, develop very mild signs and symptoms. 85% of cases infected with the poliovirus are inapparent cases. They do not show any signs and symptoms ever. The ones who show end up with paralytic polio, but the others, they just get infected, spread it, but never show any of those signs and symptoms of paralytic polio. They just have some diarrhea, which is non-specific. So, those are the inapparent cases. And then there are some undiagnosed. They have everything, but we are not able to reach them or they are not able to reach us, right. So, what is the objective of screening then? The objective of screening is to lower the waterline. The objective of screening is to lower the waterline. So, if I lower the waterline, if the waterline comes here or comes here or comes here, what will happen? I will be able to detect more and more of the diseased people, isn't it? I will be able to find out more and more of the burden of the disease in the community. So, what is the objective of screening? The objective of screening is to detect the unknown burden of the disease in the community, in the general population, right? Clear? Okay. So, from the concept of iceberg phenomenon, we have understood why we do screening at all or what is the goal of screening per se. Any doubts so far? This part is okay? So moving on then, what is screening? So this is the definition that you should know and you should remember, right? So what is screening? It is the presumptive identification of unrecognized disease or defect, right? It is the presumptive identification of unrecognized disease or defect by the application of tests, examinations or procedures which can be applied rapidly. So there are 4 important components of this definition. First and foremost is, it is the presumptive identification. Matlab by screening I am trying to say that these healthy people, these apparently healthy people probably have the disease. I am not going to give them the diagnosis by screening. By screening I am going to tell you, you are apparently healthy, you are not a patient, you did not come to me. But by looking at you, I have found out that you probably have the disease. So if you probably have the disease, now you are a probable patient. So then I will do diagnostic tests on you and I will see whether you have the disease or not. So always remember, a screening test, if you are doing a screening program, do not give a diagnosis to people out of that. That is not the objective of screening. Screening does presumptive identification. I think that probably you have disease. Why? So that I am able to find, rather than finding disease here where it has already got severe consequences, I will like to find disease here, 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 so that I am able to act in a more efficient way and prevent complications, prevent disabilities, prevent deaths and all of that. Isn't it? So it is the presumptive identification of unrecognized disease or defect. So neither the health system nor the patient or nor the individual per se was aware that the disease or defect was there. That is why I am having to do screening. Otherwise they would come to me, I would do diagnosis. Isn't it? So it is the presumptive identification of unrecognized disease or defect. Okay. Now while we do this, we can do specific lab tests. We can simply do an examination, just measuring the BP. Or we can do some procedures. For example, maybe we do a FNAC, we do a biopsy, right? So some simple tests, examinations or procedures. But ideally, where will you do screening? Will you do screening only to 1 or 2 individuals coming to you? No, we are doing it to the general population. We just saw, we are doing it to the general population to detect the underlying burden, isn't it? So if we have to do it to the masses, to huge number of people, it is essential that the screening test be one which can be applied rapidly. A screening test should not consume a lot of time. It should be rapid, right? Quick, so that it is able to cover large number of people quickly. Okay. So it's a presumptive identification of unrecognized disease or defect by the application of tests, examinations or procedures which can be applied rapidly, right? So things to remember, that it is applied to apparently healthy individuals, not to patients, right? It is applied to apparently healthy individuals. We might apply it to patients, but then for patients who have come for some other thing. For example, a 40-year-old individual has come with cough and cold. The national program tells you that any individual above 30 also needs to be screened for hypertension. So in terms of hypertension, they are apparently healthy. They have come for cough and cold, but you are screening them by measuring the BP. Rapid test performed on apparently healthy to give a presumptive. Once I measure hypertension, if the BP is elevated also, then and there I won't write you are hypertensive. I will advise them on lifestyle modification, I will measure again after 15 minutes, I will have some criteria based on which I will do some assessments and then only go and establish hypertension. I won't give a diagnosis based on one measurement, isn't it? So this is the example of screening. So it is done on apparently healthy individuals, not on patients, right? Next, it sorts out those who probably have the disease from those who probably do not have the disease. So it's a presumption, it is not an identification. Always remember, screening does not provide a diagnosis, it gives a presumption, probability that you probably have the disease, right? So it is not intended to be diagnostic, right? Why it is not intended to be diagnostic? When I teach you sensitivity, specificity, positive predictive value, negative predictive value, then I will explain you. Okay, later on in another session, we will explain you why it cannot be diagnostic. Okay, because when suppose a test is applied to 100 people, okay, now that test is 99% accurate. How many times will you become wrong? Only one time. Now imagine that same test is applied to 1 crore people. If it has got a 99% accuracy, how many times will you be wrong? 1 lakh times. So 1 lakh times you will be giving people misdiagnosis. People who do not have the disease will be diagnosed to have the disease. That is why a screening test should not give diagnosis. Clear? It should not intend to be diagnostic. It is giving you presumptive identification. Clear? So far we are good. So we have understood Iceberg phenomenon and what screening per se is. Very good. So now, when can we do screening? The need for a detectable clinical, preclinical phase, isn't it? The need for a detectable preclinical phase. So as I was explaining, any disease, it has a biological onset. For infectious disease, it is infection. For other things, it can be a pathological, biological, for example, for cancer, it is a cardinal mutation. So it will have a biological onset. After biological onset, right then and there, you do not have the signs and symptoms. There will be a phase of pathogenesis or pre-pathogenesis, a period. Then there will be signs and symptoms, then the disease, isn't it? So for you to be able to do screening, it is required that there is a time between these two events. Between infection or between biological onset and between overt signs and symptoms, there has to be a time period. That time period is the time period in which you will intervene and you will do early detection, and then you will try to do prompt treatment, secondary prevention, isn't it? Early detection and prompt treatment. So, but that time has to be there. If that time is not there, can you do screening? No. For example, rabies, isn't it? Dog bites, person will develop rabies. Tetanus, if it goes, spores go, that person will develop tetanus. So you cannot screen for them, isn't it? So there has to be a time period between the biological onset and the symptom onset for you to be able to intervene effectively in the gap. So the need for a detectable preclinical phase. So any disease which we are going to screen for must have a detectable preclinical phase. If it does not have that, then we cannot screen for that particular disease. Okay? Road traffic accident, can you screen for it? No. So you cannot screen for it. Lightning strike, you cannot screen for it, isn't it? Biological onset and signs and symptoms are coincidental. No pre-pathogenesis or long detectable preclinical phase. So this is a fundamental prerequisite for you to have a screening program, that the disease process must have a detectable preclinical phase. Clear? So moving on. So what are the differences between a screening test and a diagnostic test? This is a very common question that comes in your exam. What are the differences, or differentiate between screening test and diagnostic test? Screening test and diagnostic test are not the same. Explain why. Right? So as we have discussed these things already, so for diagnostic test, who are the people whom we are going to do diagnostic test? Patients and people who have already screened positive, isn't it? But screening test we are going to do on general population or apparently healthy people, isn't it? Or people having some risk factors, right? The objective is to sort out probably infected or disease. For diagnostic test, the objective is to arrive at a definite diagnosis, right? Cost and speed, as screening tests have to be applied to large populations, they must be cheap, rapid and simple, not too invasive, not too painful, not time consuming, easy to administer, isn't it? So, cheap, rapid, simple. Diagnostic tests, they can be often expensive and time consuming, isn't it? For example, a biopsy. If I say that I will screen the general population for breast cancer with biopsy, is it acceptable? No. But if I say I will just self breast examination, I will teach people self breast examination, they will examine themselves, is it acceptable? Yes, isn't it? So, that is the difference between a screening test and a diagnostic test. But if by self breast examination I start labeling people as breast cancer, you understand the problem? Everyone who has any lump will feel, okay, I have breast cancer. So, a screening test cannot give a diagnosis, right? Accuracy, so it has to be, a screening test has to be very sensitive. What do we mean by sensitivity? We will come to its detailed discussion later, but just so you know, sensitivity of a test is its ability to detect disease among those who are truly diseased, right? So, people who are having the disease, what is the ability of the test to detect disease among them? That is sensitivity. So, for a screening test, we want that everyone who has the disease should be screened positive. This will lead to many people who do not have the disease also being screened positive, but later on by diagnostic test we will be able to remove them. But for a screening test, it must be able to detect all or most of those who really have the disease. So, what is sensitivity? Sensitivity of a test is its ability to truly detect those who already have the disease, right? What is specificity then? Specificity is the ability of the disease to correctly identify those who do not have the disease. So, for a diagnostic test, think of a diagnosis like HIV. If you give someone a diagnosis of HIV, their entire life changes. It has got social stigma, it has got lifetime consequences in terms of associations, it has got a lifetime burden in terms of taking medications. So, when you are giving that diagnosis, you must be very sure that a person who does not have HIV, you are not giving them a diagnosis of HIV, isn't it? So, a diagnostic test must be able to correctly identify those who do not have the disease. That is, those who do not have the disease, it should not label any of them as having the disease, isn't it? So, a diagnostic test must be specific, a screening test must be sensitive. They must be both, but the world is such that if you increase sensitivity, the specificity drops, and if you increase specificity, the sensitivity drops. So, for screening tests, we prioritize sensitivity. For diagnostic tests, we prioritize specificity, right? And initiative, so usually diagnostic test, a patient is coming. So, the initiator of that particular interaction is the patient or the individual. But as far as screening is concerned, we as the health system want to detect the burden of the disease. So, the initiator here is the doctor or the physician or the public health system, isn't it? So, is this clear? The differences between screening test and diagnostic test. Clear with everyone? Any questions? No. Is it okay? Are you able to understand, or is it going? No, na? It's okay, na? Good. So, next then, why do screening? What is the purpose of screening? What is the purpose of screening? First and foremost, as we know with ethics, the first and foremost purpose is case finding. It is for the benefit of that individual only. If a person gets diagnosed with breast cancer in stage 3 or stage 4, then their chances of 5 years survival are minimal. But if they get diagnosed in stage 1 or in breast only disease, then they will be able to lead a almost normal life after 6 months. Isn't it? So the objective of screening, one of the main purposes of screening is case finding. This is known as prescriptive screening. Why do we write prescriptions? We write prescriptions to cure individuals, isn't it? So when we are doing screening for the direct benefit of a particular individual, then that type of screening is known as prescriptive screening or case finding, right? Next is prospective screening, screening for disease control. So suppose there is one individual who is reporting tuberculosis. After that, I am going and that person is living in a very densely crowded area, maybe in a slum. Then once I get that diagnosis of tuberculosis in that individual, I am going to the community and I am looking at 50 houses around that individual's house and I am screening everyone for tuberculosis. Now here when I am doing this, I have two objectives. One is, if anyone is diagnosed with tuberculosis, I will treat them. But the other objective is that if anyone is unknowingly spreading tuberculosis, then I need to stop that spread as well. Right? In COVID, apparently healthy individuals entering malls were being subjected to thermal screening or rapid tests, isn't it? Why? So that they are they sick? No. And if they are maybe 20-30-year-olds, they are not going to be very sick also. But still, why am I screening them? I am screening so that they do not spread it to vulnerable people. So this is prospective screening, where you are doing screening for the purpose of disease control. I am doing screening so that the disease does not spread in the population and the community. Right? Clear? Third objective can be for the purpose of research or generating health system data. That okay, I have a national tuberculosis elimination program. Now that national tuberculosis elimination program has to be run by the central government and the state governments. So they need budget. Now to formulate the budget, they require an estimate, no? That how many patients are there in this country having tuberculosis. Otherwise someone may suggest that there are only 1,000, someone will suggest there are 1 lakh, someone will suggest there are 10. So the budget will vary hugely, isn't it? So for research purpose and for the health system purpose, we must have an estimate of the burden of a particular disease in the community. Even for that, we do screening, right? So screening with a purpose of generating data for research and for health systems, isn't it? And the fourth purpose is screening itself often provides health education, right? In a country, suppose in a country like India, there are many pockets in our country which will have 40-50% literacy rates. Even in places having good literacy rates, what is the awareness of cancers like breast cancer, oral cancer, cervical cancer? Is every rural individual aware? No, na. Now suppose you go to the village and you say that this Sunday I will go and I will screen everyone, just I will look at their mouth for any oral precancerous lesion. So that screening initiative itself is going to educate that village that okay, oral cancer is something like this. And just by looking with a torch, we can identify precancerous lesions and stop the disease at a stage at which it creates no problems, isn't it? So screening programs themselves have a purpose of health education or awareness also, right? So these are the 4 main purposes of screening, but always remember the first 2, right? Prescriptive screening and prospective screening. Along with that, we also do it for research purposes, and as a screening itself serves as an opportunity for health education, right? Next, what are the types of screening? What are the types of screening? So there are some diseases which are present in very high numbers among many people, and the test to screen for them is very cheap, very rapid, very easy. For example, hypertension. Only need to do a BP measurement, no problem. So for diseases like this, we can do mass screening. Or say for anemia, you can just check pallor like this. For severe anemia, just check pallor like this. So for these diseases, we can do mass screening. Mass screening means we are screening the entire population, screening everyone. Every individual above the age of 30 needs to get their BP measured at least once, right? So that is mass screening. Now there are some diseases where the disease is present in specific populations, populations which show certain high risk behaviors. For example, HIV/AIDS. Now usually people who are having monogamous relationship or not having any relationship or are in a married relationship have less likelihood of contracting HIV. Contrary, there are some high risk populations, maybe migrant population, sex workers, truck drivers, males having sex with males. Then you have that IV drug abusers. They are showing some high risk behaviors which increase the likelihood of HIV. Now HIV screening, it requires 2 rapid kit based diagnostic tests in which you have to put blood. So it is not as simple as doing a BP measurement, and each of those test kits have a cost, right? So, and it requires you taking blood. So why will anyone and everyone do it, right? So for these kind of diseases, we do high risk screening. So where the disease occurs only in a population showing some risk factors, then we can say that okay, only in those high risk populations we will screen for this particular disease. This is known as high risk screening, okay, typically done for HIV, right? Next, opportunistic screening. So see, every people above the age of 30, can we reach out to them? It is difficult to reach out to them, going to their houses, measuring BP, it's difficult. But what we can do, every individual above 30 in a span of 5 years visits a healthcare provider once or the other for any reason, maybe diarrhea, maybe cough and cold, maybe anything, maybe routine checkup. So if we measure them for BP whenever they come, that is known as opportunistic screening. That I got an opportunity and I screened. They did not come for hypertension, they came for cough and cold, they came for a foot injury, they came for a cut, but I measured BP. So I used the opportunity to screen for another disease in a patient, but with respect to this disease, he or she is not a patient. He or she is apparently healthy with respect to this disease, isn't it? So here also it is opportunistic screening. It is done for hypertension and diabetes. You go for any complaint, you go to a doctor. If you are aged above 30, have obesity, you will be screened for. You also do a fasting blood sugar and HbA1c. So you will also be screened for diabetes, isn't it? So that is opportunistic screening. And sometimes some diseases require multiphasic screening, where you have one screening test which is not very accurate, but it detects any lump, but it is not very accurate, okay. And then you have another screening test which has got some risks, is little bit invasive and cost, it has got some cost, but it gives a more accurate result. So what you do, you make the screening process multiphasic. For example, with breast cancer, you say that all people, you do self-breast examination. Now anyone who has anything in a self-breast examination, if they are aged below 40, they should get a USG done. If they are aged above 40, they should get a mammogram done. Both are screening tests. Realize USG or a mammogram does not give you a diagnosis of breast cancer. It says that you probably have a pre-malignant or malignant lesion and that needs to be evaluated. But will you do USG and mammogram for everyone? Expose everyone to X-rays? Mammogram involves X-rays. Why involve everyone to X-ray? So first you ask them to do a self-breast examination. If they find a lump, Then they come to you. Then you do a mammogram or a USG. So it has got two sequences. First a self-breast examination followed by a mammogram or a USG. Right? This is known as multi-phasic screening, where you do two tests in sequence or simultaneously to do screening. Okay? Like for HIV, I said we do two tests, two rapid kit tests. Okay. So these are the different types of screening that are done, right? Mass screening, high risk screening, opportunistic screening and multiphasic screening. Screening can also be classified as active screening and passive screening. So if you look, mass screening and high risk screening are active screening. People are not coming, we are going. Health system is going to people. Opportunistic screening is a passive screening. People have come and we are utilizing that opportunity to screen. Okay. So moving on, do we really need to screen? Just because we can, does it mean we should? Just because we can, does it mean we should? The answer is no. We must only screen if screening provides visible benefits. Isn't it? Suppose there is a disease, that disease does not have any cure. So if I am screening for that, I am giving people a diagnosis. Now with that diagnosis, what will they do? It does not have any cure. So all they will get is trauma, anxiety. Without knowing, they would at least be happy and die at some point. Now they will be sad for that entire period and then die at the same point. So no point in screening there. Right. There are some diseases where even with screening, I cannot change the outcome. Matlab, with a particular cancer, that person would live for 5 years. I detected that cancer early. I did the surgery. The patient again died after 4 years. No point of screening. So just because we can do screening does not mean we must. So when should we do screening? So there is a criteria. There is a WHO criteria that was proposed in 1968 by Wilson and Junger. It has 10 points. So we must evaluate those 10 points and decide whether the disease requires a screening program, yes or no, right? So the evaluation is divided into 3 things: some characteristics of the disease, some characteristics of the test and some characteristics of the health system or the treatment. If those are met, then only we should do screening, otherwise it will only create unnecessary burden. So what are the characteristics of the disease? First of all, the disease must be an important public health problem. So when is a disease an important public health problem? কখন বলবে important public health problem একটা disease কে? When it has a high prevalence in the community. তাহলে public health problem হয়ে যাবে? Cough and cold, high prevalence. Is it a public health problem? No. So it should have a high prevalence and a high burden in terms of morbidity and mortality, right? It should have a severe consequence and a high prevalence, right? So then we will call it an important public health problem. So if a disease is an important public health problem, that is one criteria. A very rare disease happens 1 in 3 lakh population. Any point in screening? No point in screening. Next, it must have a, as we discussed already, it must have a recognizable, detectable preclinical phase. If the disease is going rapidly from infection to disease, we cannot screen, we do not have the time. So it should give us a preclinical period where we will be able to screen, isn't it? And thirdly, we must understand the natural history of disease. We must know that okay, the disease begins with infection, goes through these pathological changes and then manifests as this. If it is completely unknown, we cannot screen. Like COVID, initially the first 3-4 weeks of COVID, we were not knowing anything. How COVID happens, how it spreads, where it spreads, what is the route of spread, what causes COVID. We were not aware of anything. We could not screen. So we must understand the natural history of a disease for us to be able to screen that particular disease. For diseases where we still do not understand it properly, we cannot screen. Say Alzheimer's, Parkinson's, we are not able to screen very well because we do not understand what exactly is, how is it beginning at very early stages. Still research is going on. Ambiguity is there, right? So three disease characteristics: it must be an important public health problem, it must have a detectable preclinical phase which is sufficiently long, and thirdly, we must understand the natural history of that particular disease. Okay. Next, what are the characteristics of the test? As we said, the test must be valid. So validity of a test is evaluated through sensitivity and specificity. Okay. So the test must be a valid one and likely a highly sensitive one, right? Next, the test should be a reliable one. The test being done on repeated times should give the same result. First time I did, okay, it positive, then I did again, it came negative, third time I did, it came ambiguous. Children, it must give the same result on repeated application. So it must be reliable. So it should be valid, it should be reliable. Thirdly, most importantly, it must be acceptable. I cannot go about doing per vaginal examination of all women to screen for cervical cancer. It is not possible, isn't it? So for a screening test to be a good one, the test has to be acceptable to the people. I cannot go about doing a biopsy. So every oral cancer pre will go about doing a biopsy. No, not possible, right? Not acceptable. So it has to be valid, it has to be reliable, it has to be acceptable, and it has to be safe. Apparently healthy individual, you screen, out of that screening test, that person develops sepsis, health system bhangchur, hospital bhangchur, isn't it? So it has to be safe. A screening test, you are doing it not on a diseased person, you are doing it on an apparently healthy individual. So safety is of utmost importance. So 3 disease characteristics, 4 test characteristics: valid, reliable, acceptable, safe, right? Again 3 health system characteristics, that there must be an available treatment. If there is no treatment, what is the point of screening? Okay, there must be an available treatment. Next, you must have the facility for the treatment. You have the capability to treat only 100 people with a particular disease, and you are going about detecting 10,000 every month. What will those people do? They cannot get the treatment. Your health system is saturated. So every month you are generating 9,900 people who know that they have the disease, but they do not have the hospitals or the doctors to get treated. So your health system should have the ability to cater to the people you are diagnosing by doing screening, right? So screening you do only when you have got some unsaturation in your health system. If it's completely saturated, you do not go about doing screening, isn't it? Thirdly, it has to be cost effective. The cost of screening is more than the effect of the disease. No point in screening, isn't it? So it has to be cost effective. Cost benefit ratio देखना होगा. Screening program का cost कितना है and what benefit, how much disease it is preventing, how much burden it is preventing, what is the monetary calculation of that burden, right? So health system wise, a treatment must be there, adequate resources in the healthcare system must be there to be able to give that treatment to the people we are screening as positive, and thirdly, it has to be cost effective. So these are 10 criteria that we must look at a screening test to be able to use it, right? Word of caution, there is always the risk of overdiagnosis, always the risk of overdiagnosis, okay, false positive. So do not diagnose with a screening test, only say that you are presumptive positive. You need to be subjected to a diagnostic test. If you start diagnosis people with screening test, it will lead to disastrous consequences. Lot of stress, anxiety, depression in the society, right? False positives, as I said. Also false negatives. People who really have the disease, screening test could not detect it. So apparently they felt, okay, I do not have the disease. They're going, they won't come back for the next 5 years because you have labeled that they do not have the disease. So when we are doing screening, we are more worried about false negatives than false positives. If we have false positive, we can always run a diagnostic test and tell that no, it was a false positive, you do not have the disease, go back, come back again after 6 months. But if you are giving false negative by a screening test, it can have disastrous consequence. They have the disease, you could not detect it. Okay. And lastly, there are some epidemiological biases which can happen. So lastly, there are some epidemiological biases which can happen. Okay. So these are some common screening tests. Just remember them. Okay, I have given the example so that you are able to utter the names in the exam. Okay. So just read them. What are the commonly screening tests we do for cancers, for NCDs? Okay. Thank you.